البداية. اللي مش حابب يحضر لأي سبب يتفضل. اللي حاسس نفسه مش قادر يتحمل نص ساعة من غير ما ينطق يعني هيك كلام برضه يتفضل يطلع. اللي مش انترستد لأي سبب برضه يطلع. اللي في أي لحظة حسيت إنه أنتم متضايقين وبتطلعوا برضه مع السلامة يعني، ولكن شرط واحد بس لو سمحتوا الهدوء. تمام؟ لو سمحتوا من غير كلام. So كمان صورة ولا؟ So today we're going to start the third part of gastrointestinal tract pathology. We're going to talk about the lower gastrointestinal tract, mainly the colon and appendix. We would go through some neoplastic processes, and then we will talk about the inflammatory bowel disease. This slide represents a gross appearance of a colon polyp. As you know, polyp means finger-like projection into the whatever the organ, but into the lumen of the hollow organ. This polyp here have a stalk or pedicle. This part represents the stalk or pedicle, and this is the growth present on the top of the pedicle. The pedicle represents a fibrovascular core covered by normal colonic mucosa, and the polyp proper is formed of a neoplastic colonic epithelium. This is an adenomatous polyp, show a hemorrhagic surface. This hemorrhagic surface correlates with the positive stool for occult blood. The bleeding surface of the polyp might lead to iron deficiency anemia if it goes undetected over a long period of time. The adenomatous polyp are classified according to the histological appearance into three types: tubular adenoma, villus adenoma, and tubulovillus adenoma. The tubular adenoma is formed of tubules or elongated tubular-like structures lined by the neoplastic adenomatous epithelium. The villus adenoma formed of villiform-like appearance, and the tubulovillus adenoma is a mixture of the two components in the same polyp. Here is an endoscopic view of a polyp. It is pedunculated because there is a neck or stalk or pedicle connecting the body of the polyp with the GI wall. This part of colon also contains polyps, but in this case there are numerous polyps, actually more than hundreds and thousands of polyps scattered all over the colon wall and the mucosal surface of the colon. This case is known as familial adenomatous polyposis. Familial means it is inherited disease run in families, and adenomatous because it led to formation of colon adenomas which progress or undergo malignant transformation into colon adenocarcinomas, and polyposis due to the large number of polyps present at the time of diagnosis. Usually, these patients have an inherited mutation of the ABC gene, the adenomatous polyposis coli gene. The abbreviation is ABC gene. Mutation of this gene will lead to formation of numerous polyps and facilitate the transformation into adenomas and carcinomas. These patients usually present with younger age group and found to have adenomas and carcinomas usually around the age of 20 or even before. This condition is associated with 100% risk of malignancy, which means all the patients diagnosed with adenomatous or familial adenomatous polyposis will develop malignant colon cancer. Another example of FAP syndrome or familial adenomatous polyposis. Here you can recognize the numerous scattered polyps all over the mucosal surface of the colon. This is another example. Actually, the normal mucosa is not apparent and obscured by the huge number of polyps scattered all over the mucosal surface of the colon. If a familial adenomatous polyposis associated with extra colonic manifestation like development of osteomas or epidermal inclusion cysts, the name changed into Gardner syndrome. So, Gardner syndrome means the association between familial adenomatous polyposis with osteomas and epidermal inclusion cysts. The mode of inheritance is autosomal dominant in both categories, the FAB and the Gardner syndrome, and also the risk of malignancy is the same. Osteoma و epidermal inclusion cyst في السكن. Here is another type of inherited colorectal cancer, the syndrome known as hereditary non-polyposis colon carcinoma, and the abbreviation is HNBCC. This syndrome characterized by fewer number of lesions in comparison with the familial adenomatous polyposis, and the age of patient usually are older than familial adenomatous polyposis. Also, the genetic background or genetic abnormality is different, in which the HNBCC usually is associated with abnormality or mutation of mismatch repair gene. Okay, mismatch repair gene. In familial adenomatous polyposis, as we said, it is ABC gene, adenomatous polyposis coli. But in HNBCC or hereditary non-polyposis colon cancer, it is mismatch repair gene, which will lead to microsatellite instability. Here is a cecum. This dilated part represents the cecum, and this thin part represents the terminal ileum. You can notice here a few lesions scattered or polyps scattered on the cecum and ascending colon. Under the microscope, the adenomatous polyp, regardless of the underlying or the associated or the syndromic association with these polyps, they show similar morphological appearances. Here, this part represents normal colonic mucosa. These are the crypts, lined by single layer of simple columnar epithelium, with the nuclei are arranged on the basal side, and goblet cells are, or the mucin is accumulated on the luminal surface of the cell, leading to formation of these vacuoles of mucin or goblet cells. These surface also represent the same picture, with the nuclei are basally located and the presence of numerous goblet cells. On the opposite side is an example of colon adenoma. Here the shape of crypts is different. The normal longitudinal, nicely arranged crypts are absent and replaced by these irregular and crowded crypts. The nuclei are basally arranged in this crypt, but they are stratified. Here you can notice nuclear stratification in comparison with the single layer of nuclei on the normal side. On the surface epithelium, the nuclei are much more stratified and reaching up to the luminal surface. Also, the number of goblet cells is reduced and is almost absent on the surface epithelium. So, this side represents the normal colonic mucosa, and the opposite side represents adenomatous polyp. Okay? Any questions so far? This gross picture represents villus adenoma. Here you can notice the villus appearance of the mucosal surface in comparison with the pedunculated polyps seen previously. So this is villus adenoma. Also, there is no pedicles connecting the adenomatous lesion with the mucosal wall. This line represents muscularis propria of the colon wall, and this is the pericolonic fat. The epithelial lesion or the adenomatous lesion is directly attached to the underlying mucosa without a connecting pedicle or stalk. So this is a sessile adenoma. Sessile means that there is no pedicle or stalk connecting the adenomatous part or the polyp with the underlying colonic wall. Usually, villus adenoma reach more larger size than pedunculated or tubular adenomas. This is the microscopic appearance of villus adenoma. Here you can easily notice that the crypts are much more longer than tubular adenoma. The surface epithelium is almost not appear here in this picture, but the crypts are very long, with this villus tapering end of the epithelium at the end of the villus architecture. In the center there is a fibrovascular core, and this is the adenomatous epithelium lining the fibrovascular core. Villus adenoma usually associated with higher risk of malignancy. It is up to 40%. This part of rectosigmoid colon. ممكن تشيل الموبايل أو اطلعي برا أنت وياه. This is an example of rectosigmoid carcinoma. This part represents a normal rectosigmoid wall. The mucosa is glistening and the mucosal surface is unremarkable for any lesion, but there is an interruption with infiltrative circumferential mass with elevated or raised margin. It is an ulcerating infiltrative tumor. The depth of invasion of the colonic adenocarcinoma will determine the tumor stage. If the tumor is limited to the mucosal layer, so it is considered T1 stage. If it reached the muscularis propria but did not extend into the pericolonic fat, it is considered as T2. If the tumor reaches pericolonic fat and is still not reaching the serosal surface, it is T3. And once the tumor reaches the serosal surface or perforate or become adherent with adjacent structure, it is considered as T4 tumor. Okay, so the depth of tumor invasion is an important point to be considered in the diagnosis of colonic cancer. طيب high segment of rectosigmoid. This is one end and this is the another end. The specimen is opened longitudinally. Okay, and this is the ulcerated circumferential tumor here. Okay, this part represents normal colon. This is an endoscopic view of colonic adenocarcinoma. This is the lumen of the colon and the normal adjacent mucosa here, with this fungating and bleeding mass within the colon lumen. It represents colonic adenocarcinoma. Surface ulceration is a frequent finding in colonic adenocarcinomas due to friction with the food particles led to loss of the surface epithelium and the bleeding. The prolonged bleeding will lead to microscopic hypochromic anemia as one of the clinical features of colon cancer. So colon cancer or GI bleeding in general is considered one of the most common causes of iron deficiency anemia, especially in elderly. Another example of colon cancer with this circumferential mass encircling the colon wall. Usually when the mass go deep infiltration or extensive growth into the lumen, it will interfere with the bowel motion or normal bowel motion, which might manifest as abdominal pain, constipation, or even present as acute abdomen in cases of intestinal obstruction. This is another endoscopic view of colonic adenocarcinoma with this fungating mass protruding into the colon lumen. Another example of colon cancer, but this slide represents a fungating mass or exophytic growth type. Fungating mass means projection of the tumor growth into the lumen of the colon rather than infiltration into the fibromuscular wall of the colon. The fungating tumor usually manifests as a constipation or intestinal obstruction according to the size and extent of obliteration of the colon lumen. And this is another example of adenocarcinoma on lower GI endoscopy. You can notice easily the ulceration and hemorrhage at the surface of the tumor. This is adenocarcinoma arising on top of villus adenoma. Here the surface of the tumor is polypoid and nodular. It looks rich brown due to foci of hemorrhage. As we said earlier, hemorrhage from tumors will be detected on as occult blood on stool analysis. This is a microscopic examination of the carcinoma arising from villus adenoma. Here you can easily recognize the presence of adenoma in this part, the adenomatous growth in the form of elongated crypts. The epithelial lining is a stratified columnar epithelium with a nuclear stratification and depletion of goblet cells. Adjacent to the adenomatous lesion, here is a well-differentiated adenocarcinoma. You can notice that the crypt architecture is much complex or more complex than the adjacent adenomatous part. The epithelium is more anaplastic with highly basophilic and pleomorphic nuclei. At this point, we cannot recognize any area of invasion beyond the mucosa, but examination of more sections from the tumor might detect foci of invasion. There is difference between grading of tumors and staging of tumors. Grading means how much this lesion is similar to the primary or benign tissue of origin. Yes, means the degree of differentiation. This is what's meant by grading. And usually colon cancer are graded as low grade and high grade tumors, or well differentiated, moderately differentiated, and poorly differentiated tumors. Well differentiated tumors means that this tumor is very similar to the benign or normal colonic tissue in terms of well-formed glands or crypts. The moderately differentiated means the formation of crypts is less than the well-differentiated type, and poorly differentiated means we cannot recognize the tissue of origin of this tumor. Okay? This is the meaning of grading. Staging means how deep the tumor is invading through the colon wall. As we mentioned before, if it is limited to the mucosa, it is considered as T1 tumor. Infiltration of submucosa and muscularis will be considered as the T2 tumor. Invasion beyond the muscularis into the pericolonic fat is the T3, and involvement of the serosal surface or infiltration into adjacent structures is considered T4. Okay? This is an example of moderately differentiated adenocarcinoma of the colon. These are glandular or tubular structures formed by malignant glands in which there is high NC ratio, hyperchromatic, pleomorphic nuclei, and scattered mitotic figures. Also within the lumen there is extra vasated or mucin deposition within the lumens. This is another example of histologic appearance of adenocarcinoma in which the glands are large, irregular, lined by the malignant epithelium, and there is wide areas of central necrosis known as garland necrosis. The presence of dirty necrosis within the lumina is a highly suggestive feature of colonic origin, especially in cases of metastasis either to the liver or lymph nodes. High power examination of the malignant tumor of the colon will reveal high NC ratio of the cells, large hyperchromatic nuclei, loss of goblet cells, and frequent mitotic figures. This is a mitotic figure, another example of a mitosis, and this is also an example of mitosis. The lumen contains mucin, as we mentioned earlier. Okay? Any question about lower GI tumors so far? So, let's start.
T1 كانت mucosa بس.
يعني ما وصلت للمصل بعد. about the benign or inflammatory conditions of lower GI tract. This slide represents a case of diverticulosis. Diverticulosis means herniation of the colonic mucosa through the muscular or muscularis propria of the colon, with formation of pockets or outbouching from the lumen. This is part of a sigmoid colon here, and these nodules or projections represent diverticuli. Okay? This is the gross appearance of diverticuli. Diverticulosis usually occur as a consequence of increasing the intracolonic pressure due to constipation usually, and it is or it affects elderly more frequent than young patients due to the slow motion of the bowel loops in elderly and the fecal impaction, which will increase the intracolonic pressure and herniation of the mucosa through the weakened muscularis propria. Another example of diverticulosis, these projections represent the diverticuli outbouching from the muscular layer of the colon. It is more common to be present on the left colon than the right colon, because on the right side the fecal material is semi-solid and it gets solidified more on the left side, which makes the motion more difficult and lead to increase in the intracolonic pressure. By lower GI endoscopy, the diverticuli usually appear as opening in the mucosal walls. These openings represent diverticuli on lower GI endoscopy, and this is a gross appearance of diverticuli. This part represents the mucosal surface, and these bits represent the opening of diverticuli. ايش؟ هدول؟ هاي يعني؟ هدول ابيبلويكا ابنديسي اسمهم ابيبلويكا. هاد normal anatomy. Normally the colon is surrounded by pericolonic fat. Two types: the mesenteric fat, which surround the fibrovascular tissue or blood supply into the colon, and epiploica appendices. The name is epiploica appendices. Usually these appendices are present along the anti-mesenteric border. Okay? They are not diverticuli because they are formed of fat. They are formed just of fat. A gross appearance of diverticulosis. This is the colonic wall here, and these are the diverticuli, which represent a mucosal herniation through the weak muscularis. So, in case of diverticulosis, you would not see muscularis propria surrounding the herniated mucosa. Okay? Diverticuli usually get impacted with the fecal material, and secondary infection will lead to a complication known as diverticulitis. Diverticulitis means inflammation of the diverticuli. Okay? Histological examination will show the normal colonic mucosa. This is the neck of diverticulum, which frequently get ulcerated due to friction with the fecal material, and the mucosa here is directly adjacent to the subserosal fat and fibrous tissue and devoid of muscularis propria. In case of diverticulitis, the inflammation will extend from the diverticular mucosa into the adjacent colonic mucosa, and this is an example of diverticulitis. Here you can easily notice the hemorrhagic and edematous surface of the colonic mucosa due to hemorrhage and inflammation. Another complication of diverticulitis is perforation. This is a diverticulum which gets perforated with formation of necrotic tissue at the site of perforation here. Usually, perforation of diverticuli is a surgical emergency because if it left untreated might lead to peritonitis, septic shock, and death. Okay? So diverticulosis, diverticulitis, and rupture of diverticulum should be considered as surgical emergency and get treated. Okay. According to the stage of diverticulosis or the clinical state, if it is still simple diverticuli without complication like diverticulitis or rupture, the changing lifestyle of patient, increased dietary fibers, maybe exercise. Yes, no, it's not healing, but it will reduce the risk of complication. If it presented during a complication like diverticulitis, it has to be covered by antibiotics, lift the patient MBO till the resolution of this inflammation. If the patient present with perforation, which is considered as surgical emergency, we have to take this segment of colon out to, yes, and make peritoneal lavage to get rid of the debris and inflammatory content within the peritoneum. Okay? So it depends on the clinical state of the patient. This is another example of rupture of diverticulum. This lesion represents the ruptured diverticulum. It gets a brown appearance, and this trocar represents the site of rupture. This picture represents the hemorrhoids. This patient have perianal hemorrhoids here. It is an internal hemorrhoid but get prolapsed through the anal verge into the outer surface of the anus. Hemorrhoids are formed of dilated venous or dilated submucosal anal veins, which might get thrombosed if prolapsed out of the anal verge and get thrombosed. Usually hemorrhoids occur as a consequence of chronic constipation, chronic diarrhea, or pregnancy and portal hypertension due to increasing the intra-abdominal pressure or increasing the venous pressure. Clinically, they might present as perianal itching or bleeding per rectum, and usually they appear like these tiny projections on colonic or colonoscopy. Let us start talking about inflammatory bowel disease or chronic inflammatory bowel disease. As you know, inflammatory bowel disease are divided into Crohn's disease and ulcerative colitis. So this gross specimen represents a case of Crohn's disease. This part represents a normal colonic mucosa, but you can easily notice that this part is totally unhealthy. This segment is unhealthy. Colon, it has a thickened wall. Here the wall thickness is within normal limits, but this segment is markedly thickened with induration of the pericolonic fat. As you know, Crohn's disease represents scab lesion, which means areas of involvement alternating with normal colonic mucosa. The endoscopic finding appear as inflammation, erythema, and ulceration of the colonic mucosa, with alternating with areas of normal appearing mucosa. في إشي؟ ضاع منك إشي ولا؟ Another example of Crohn's disease involving the small bowel. The mucosal surface here represents a regular nodular appearance of the mucosa due to hyperemia, congestion, and focal ulceration. Microscopic examination will show the transmural inflammation of the colon. The inflammatory cells here, which is mainly formed of lymphocyte and plasma cells, will go through the entire thickness of the colon wall, starting from the mucosa, submucosa, muscularis, and the subserosal fat. Crohn's disease characterized by or might present as granulomatous inflammation. These histiocytes are arranged in nodular pattern, forming granulomas with the presence of these multinucleated giant cells. So, the presence of granulomas on endoscopic biopsy in case of inflammatory bowel disease will be more in favor of Crohn's disease. In case of granulomatous inflammation within the colon, we have to consider infection as a differential diagnosis, and we have to run special stains to detect any microorganisms like fungal or bacterial or mycobacterial elements. Sure. As a complication of transmural inflammation, patients might develop fissures like this one, and as the fissure goes deep through the bowel wall, it might lead to formation of fistula with adjacent bowel lobe or with nearby skin surface. This is a gross appearance of ulcerative colitis. As you know, ulcerative colitis usually present by or characterized by involvement of the colon only. But in contrast, Crohn's disease might lead to involvement of any part of the GI tract, starting from the mouth to the anus. This colon of ulcerative colitis patient represent inflammation. This is the terminal ileum. This is the cecum, ascending colon, transverse, and descending colon. You can notice that the inflammation is involving the entire colon. There is no skip lesion in case of ulcerative colitis. The mucosal inflammation and ulceration will lead to formation of pseudopolyps. Pseudopolyps means it is not a true neoplastic polyp formation, but due to ulceration and loss of the adjacent mucosa, the remaining mucosal parts will appear as polypoid structures. So they are termed as pseudopolyps. A more اطلعوا لو مش حابين عادي يعني والله مش حابب يطلع على طول. This is a close view of pseudopolyps. This part represents the ulcerated mucosa here, and these pseudopolyps represent the remaining inflamed mucosa forming pseudopolypoid structures. Another example of ulcerative colitis. Here the inflammation, erythema, and ulceration involve the entire colon with sparing of the ileocecal valve here. Another example of pseudopolyps in case of severe ulcerative colitis. Here the remaining mucosal islands adjacent to the ulcerated foci appear as pseudopolyps, as we mentioned. One of the serious complications of ulcerative colitis is the formation of megacolon. Megacolon is one of the surgical emergency, and it has to be treated by surgical excision, because the risk of perforation is very high and it might lead to septic peritonitis if left untreated. Microscopic examination of ulcerative colitis will show that the inflammation is limited to the mucosal surface. High power examination will show that the inflammation of mucosa here, with a dense inflammatory infiltrate formed mainly of lymphocytes and plasma cells, there is a neutrophilic infiltration of the surface epithelium, which means this is an active state of the disease with depletion of goblet cells. This is an exudate present within the lumen as a result of the exudation of the inflammatory cells and fibrin and dead cells into the colon lumen. Another example of active ulcerative colitis, in which the neutrophils are attacking the crypt epithelium and filling the lumen, forming crypt abscess. The presence of neutrophil within the epithelial cells termed as cryptitis. The presence of neutrophil within the lumen, crypt lumen, عفوا اطلعي برا برا لا لا انت برا لانه نبهتك اكثر من مره ويعني صايره فيكي هيك اطلعي برا اطلعي برا. ما حكينا من الاول، اللي مش قادر يصبر نص ساعه من غير حكي يطلع من الاول. لهالدرجه يعني خلاص؟ طيب مليتوا اطلعوا، مش قادرين تستفيدوا اطلعوا. شايفين ان الموضوع مش مهم برضو اطلعوا. More high view of active Crohn's disease or ulcerative colitis will show the cryptitis and the crypt abscess formation. The risk of adenocarcinoma increase in case of inflammatory bowel disease, and it is usually preceded by dysplastic lesion in the form of adenomatous lesions. أي سؤال؟